Hi everyone, welcome to the Orygen, the National Centre of Excellence in Youth Mental Health webinar, Managing Complex Self-Harm in Youth, with Dr. Louise McCutcheon. I'm Lee Crothers and I'm a Project Manager here at Orygen, National Centre of Excellence in Youth Mental Health. Before I introduce Louise, we just need to go on to a bit of housekeeping. We have quite a lot of people attending the webinar. Welcome. We've got about 400 people registered. So we are going to go through some slides first and then actually have a discussion because we do want it to be more interactive. We'll try our hardest to make it interactive, but please just type in your questions and you'll see the question box. You'll see it here in your control panel. But if there's a lot of questions, I'll try and theme them together and we'll ask them at the end. If there's a lot of questions that are quite important about what Louise is talking about, I might ask you to pause and Louise has got an opportunity to talk through the question. The other thing is that all the participants will receive an email, a statement of completion of this webinar, and also this webinar will go live on the Orygen campus in the next 5 to 10 working days, so you can access it again. We will email you the link though. You can see here again how you can send in a question. Please do it any time throughout the webinar. So I'm happy to introduce Dr. Louise McCutcheon, who's a clinical psychologist who works here at the Orygen Centre of National Mental Health. She has 20 years experience, well, over 20 years experience with working with young people who self-harm or have suicidal ideation. And you're well known really in your work with early intervention for young people with borderline personality disorder.
Thank you.
It's all right.
Okay. So we're talking about managing complex self-harm in young people today. We'll be addressing this topic really because issues of suicide and self-harm are probably the most confronting and potentially stressful and anxiety-provoking topic that we can think of, or issue that we can think of in our work with young people. So we really want to have a think about how we can help clinicians to work more effectively and more confidently with these sorts of problems. What sort of things help? Usually understanding the reasons behind self-harm and suicidal behaviour. We can build our skills and we can also have more discussion between ourselves as clinicians and professionals and feel more confident in talking with young people. So that's the reason why we've decided to have a webinar on this particular topic, and we hope that it's a useful and helpful one for you. So just a word of warning, I guess, to begin with. This is not a risk training session. There are lots of available risk trainings around, and we have some resources that we've listed at the end of the webinar that will be able to help you if you're struggling to find risk training. We're assuming that either you already have some training in risk assessment or that you can refer to others to do that if you need to. Or if you're early in your career or you realise that you need to brush up on your training, that you'll go and do that as a result of this webinar. So just to sort of set the scene and make sure we're all on the same page, what are we talking about when we're talking about self-harm and risk to self? So suicide is the intentional causing of one's own death, and self-harm is when we deliberately harm oneself. And there's a whole lot of reasons or ways that people might self-harm. So we know about cutting and scratching and burning, and sometimes people do things like bang themselves or punch themselves. We're also including in our definition self-poisoning or intentional overdosing on medications or drugs. And also we're including the deliberate risk-taking that can lead to self-injury. What we're not including are things like self-starvation and other sorts of things, which sometimes clinically you might want to think about as self-harm in your discussions with young people, but usually that's not included in the literature, and so we're going to exclude those things for the purposes of today's discussion. When I'm talking with young people about work with young people, one of the things that I think is particularly important to start to think about is, you know, how we tell the difference between self-harm and suicidal behaviour. And I think in our work with young people, it's not always 100% clear what the difference is, what might be suicidal behaviour versus self-harm. I think in work with adults it tends to be a little bit clearer, and perhaps the older youth that we see, those who are over 20 or maybe even closer to 25 might be able to tell you the difference. But often when we're working with younger people, particularly adolescents, they can feel quite confused about those two things. So I think we want to be careful in our discussions. Most of the time we're going to probably talk about those things interchangeably. So we're going to be referring to self-harm most of the time, but we're also going to be mindful that we might be including people who are doing things that are pretty dangerous and may lead to suicide. So we're including both of those ideas in our definition for now about self-harm. So behaviour and intent are two different things, and what we need to remember is that when we're working with young people, they may not be particularly clear about that. So the lethality of the means that they're using to harm themselves might be quite high, and therefore their behaviour may be quite dangerous and possibly lead to death by suicide, even though their intent may not be to do that. On the other hand, we might see the alternative, which is that people might have very high suicidal intent but be using very low lethality means. And so those two things are often quite confused for young people, or quite interchangeable and not very clear. So really the message that I'm trying to give is that we need to take all self-harm seriously. One of the things that I think is very striking when you're working with young people is that if you ask them about their intent, they may not be very clear. They may be quite naive and have very limited understanding about what sort of behaviours might lead to death. Sometimes, you know, I've had conversations with young people who've said if they hold their breath in the bath, they might drown themselves. Actually, it's quite hard to drown yourself just holding your breath. So sometimes people are quite naive about the means that they're using to harm themselves. That can be quite dangerous, of course. Other young people may be quite confused about issues of finality of death. So they may have a very limited understanding or quite a naive understanding of what it means to die. So, for example, I've talked with young people who've made comments about how they would like to see the faces of the people at their funeral, and that, you know, if they're feeling angry with people, they want to show them and see the consequences of their actions, which of course is impossible if you did. So sometimes people's understanding about death being a final act is also quite confused. Other people sometimes say that their intentions fluctuate quite a lot. So their initial intention might be to die, and then they may change their mind, or they may be wanting to just regulate emotion or get rid of negative feelings, but using a fairly dangerous method to do that, and may get very close to dying. So people's intentions can also change quite a lot. And then, of course, you know, sometimes young people are really just gambling with fate, or saying, you know, I wanted to take a risk, I wanted to do something that would produce a high adrenaline rush, and I didn't really care whether that was a dangerous thing. So I think in our discussions with people about intent, I think it's useful to ask about intent, but I think we need to be quite mindful that the answers that we get back don't always tell us about how dangerous someone's behaviour is. And the bottom line is really that accidental death can happen quite easily, and therefore we need to take all self-harm seriously. And the risk of suicide is always higher in those that have a history of self-harm. So even if somebody is telling you that they're only interested in self-harming, they're not intending to die, we need to take that seriously because the risk of actual death is quite high in those people. So I don't want to scare everybody and make everybody overly anxious, but I think we need to be realistic about this topic, that in working with young people, suicide and self-harm are quite closely related. So if we stick with the idea of focusing a bit on self-harm, what do we know about it? From most of the reviews, we know that there are two really common types of self-harm, although there's a whole range of different ways that people can harm themselves. The most common are cutting and self-poisoning, and that there's been an increase in hospitalisation for self-harm. It's most frequent in young women. And we also know that most hospitalisations are for self-poisoning or overdosing. And that's even though self-cutting is actually reported to be more frequent in the community. So despite the problem that we don't collect data very consistently across Australia, we do have some evidence that self-harm rates are increasing, that in the younger adolescent sort of age group, sorry, not young adolescents, mid to late adolescents, the rates are around 16%, and in young people 20 to 25, it's more like 20%. Lifetime self-harm. We also know that there are a number of groups who are more vulnerable, and those are young women, Aboriginal and Torres Strait Islanders. We know that young people with mental illness are more likely to be self-harming, and there are other groups as well. The reasons given for self-harm can vary quite a lot. So, and I think it's important to remember that people sometimes have more than one reason at a time. So probably the top reason is self-punishment and to prevent me from doing something worse and to manage my emotions or my negative feelings. Then the most common ones. To communicate how desperate and how awful I was feeling is also a reasonably common one. And we know that self-harm is associated with a whole range of different mental health problems. That really it's a symptom of distress or a coping mechanism to deal with difficult ways of feeling and difficult experiences. It's not a diagnosis on its own, although actually recently the DSM-5 have introduced non-suicidal self-injury. I try and be very careful about the idea of non-suicidal self-injury as a diagnosis because actually we don't always know that it's non-suicidal. And self-harm is a symptom of a whole range of different presenting problems. People who are depressed, people who have psychosis, people who have OCD or PTSD, and of course borderline personality disorder. All of those groups experience self-harm at different times, and that's just the beginning. So I think I've already mentioned this, that some groups have higher rates of self-harm and suicide. The ones that I didn't mention earlier are young people in immigration detention and forensic populations, and same-sex attracted and gender diverse populations are also at higher risk of suicide and self-harm. And we need to also remember that the reason we're talking about this, although self-harm, people tend to grow out of self-harm, the rates in someone's life decrease as they get older and as they grow into adulthood. We do know that self-harm is associated with a higher risk of a number of adverse outcomes. So people can unintentionally die from some of their actions, and also maybe injure themselves seriously. And we also know that people who've had a history of self-harm are at higher rates of premature death in the future. Some of that may be from suicide, but also some of it is from the complications of their self-harming actions. And we've also been able to establish that they're at higher risk of other sorts of problems like assault. And we also know that the effects of young people's self-harming behaviour affects a whole range of people around them. So family members and those close to the young person and those that work with young people who self-harm are likely to be affected by that. And people report that they have lower levels of well-being themselves, higher levels of distress, and that parents have reduced confidence in their own parenting and feel that they lack the supports to be able to manage the self-harm. So self-harm in young people has a lot of effects on many people. Another issue that is particularly important for us to have a think about is that young people who self-harm are much more likely to hide their self-harm than they are to ask for help. And many young people have described how they've been actively discouraged from talking about self-harm or seeking help. So there are a number of barriers that might be there. That they might feel that there are negative responses from others, that there is discrimination and stigma from self-harm, particularly in emergency departments. Young people have experienced discrimination and stigma. And they feel that many people dismiss their concerns as being unimportant. Young people also say that the feelings of shame and guilt associated with self-harming can be one of the barriers for seeking help, and that people have responded to them with fear or irritation, the sort of feeling like, well, why are you coming to me about that issue? Or feeling angry, like the young person is trying to punish the parent or the other person when they are asking for some assistance. There are also concerns, I think, about the fact that workers or clinicians might, or staff at schools, for example, might be very concerned about contagion and therefore might be blaming the young person for causing problems in the school group or in the wider group, and that can be a barrier as well. There are a number of myths about self-harm, and I think that there's quite a lot of information you can access if you want to have a read about these sorts of issues and you want to inform yourself better about the misunderstandings commonly out there about self-harm. We've got an example here of the Mythbuster fact sheet that's available from Headspace, and there are other resources on the Orygen website, and in fact many resources that you can access if you want to read and think a bit more about those sorts of things. The bottom line really is that people self-harm because it works, and it's particularly important to understand that self-harm does work, particularly in the short term. So people are using a coping strategy because it works. And if we don't acknowledge that, then it's going to be difficult to shift people's behaviour. So the place to start usually is, I understand it's working for you, and now could we find some other coping mechanisms that might be actually more helpful for you? So if we move on from what is self-harm to start to think a bit more about what do we do as a response to self-harm, we need to be thoughtful about the whole range of reasons that someone might be self-harming, and that makes the one-size-fits-all kind of approach probably not to be adequate or helpful. That really we need to understand individual reasons and the reasons that are going to be most helpful in thinking about a young person's responses and what they need to learn. Usually when we start to think about self-harm and suicide, particularly preventing self-harm, we start with the idea of risk assessment, and I just want to have a little bit of time to think through risk assessments and what are they telling us and how much do we rely on them. Mostly when we're conducting a risk assessment for self-harm, we're using the same kind of risk assessment that we would for suicide. So there's no difference between those two risk assessments. We start usually by listing the risk factors that someone might be exhibiting. We think about intent, plan and means. And often our risk assessments ask us to categorise somebody's risk into high, moderate or low. And I want to just have a moment to think about the kinds of risk factors that we're going to concentrate on. I'm not going to go into them in a lot of detail because actually there's many risk factors, and I think that's part of your risk assessment training, so we're not going to go through them, but we are going to just think about the fact that there are risk factors of different kinds and that it's important to think about the difference between static risk factors and dynamic risk factors. So some things are unchanging, they're the static ones, they're about somebody's history, they're about the belonging to a minority group or perhaps being in a higher risk group. Things like gender are less likely to be changeable. Other sorts of factors, though, fluctuate quite a lot. So things like people's mood and hopelessness and access to means are things that are going to change really quite quickly. And so when we're thinking about assessing for risk, we need to be looking at both static and dynamic or acute and immediate risk factors and chronic ones.
I'm just going to slip in here.
Yep.
We're just trying to encourage people to ask some questions because we're giving you a lot of information. And we do want this to be quite interactive. And I mean, maybe you're answering all the questions, but please don't be shy. We don't think there's a stupid question at all. There is one question around schools, but we might come to that at the end of when we break a little bit. What do you think?
Well, yeah, we will. I hope this is relevant to people in schools, but I'm deliberately not focusing only on schools because I think that school responses need to be quite consistent and cohesive. And I think there are very good packages for responding to school concerns. And so we have resources listed at the end of the webinar, and I think that might be a better place for people who are interested in that question to go to.
Yeah, great.
So I hope that what we're talking about is relevant, but I think specific resources are better.
This is a good question, though, that's come up. What do young people use as means for self-poisoning? Do you know mostly or just anecdotally?
Yeah, I think that's a good question. A whole range of things. The commonly available things are probably the most frequently used. So off-the-shelf medications, and everybody's heard about people overdosing on Panadol or those sort of analgesic kind of medications, and you can even get codeine-based ones very easily. You can buy Panadol in huge quantities if you just go to discount stores. So those sorts of medications are common. And I think we could include things like alcohol if people are deliberately using it in order to overdose. So people who drink very large quantities hoping that something terrible will happen. So I would include alcohol from that point of view.
They might not have been included in the research, alcohol.
I think alcohol's a harder one to tease out. And I think, other people drink things like bleach or, the products that you find underneath the sink in everyone's house. There's lots of different things that you can get your hands on if you look around that are really quite toxic and dangerous.
Thanks. Oh, we've got another one. Could you run over the reasons why self-harm works in the short term? Because we did have a slide like that. That's a good question.
So What we know is that I'm not going to go into a huge amount of detail about that because there's lots of, you know, I'm not going to go into the biological detail. I'm a clinical psychologist, and I think we could probably find someone who's more biologically expert than me.
Yeah.
But very clearly, there are endorphins released when you engage in self-harm, much like if you go for a long run or you do something really that releases adrenaline. You know, you parachute or something like that, you get a real high from it. And people who engage in self-harm report similar sort of experience, that after cutting they feel elated sometimes and euphoric sometimes, and we know that actually people's sense of pain reduces. So there can be, you know, quite physiological sort of experiences that reinforce the self-harming.
And psychological benefits, people usually say it's a good distraction.
Yeah.
To a quick one, isn't
and
it?
it can help you. Sometimes people use it to sort of push dissociation or to trigger dissociation, and sometimes people use it for the opposite, to kind of feel grounded again. So,
in their body. So there is one more on the subject of self-poisoning. Would it be an idea to hide bleachers? That's a good question too.
Yeah.
So I think that people could take.
I think that's a really tricky kind of question, because yes, we want to restrict people's access to really dangerous things, but the other side of that is if we restrict the access, then the young person doesn't learn how to manage their own negative experiences and to engage in more helpful coping mechanisms. So what we want to do is work with the young person to build up their more adaptive coping skills, so they don't need to rely on taking overdoses or cutting or whatever the self-harm is. And I think that if we try and keep people perfectly safe, we're actually going to fail at that most of the time.
It's impossible.
We can't take all the knives away and all the razor blades away and all the Panadol away and all the bleach and everything else under the cupboard. You can't live like that, or not very successfully. So I think while we might need to do that in the short term occasionally, we don't want to do that all the time.
Yeah, it does send an interesting message to young people. If you lock everything up, that we don't trust you to be able to manage yourself.
And we don't think that you can learn how to do this. And we want to give young people messages that we want to work with them to build up their skills.
Great. We might leave the next question to later around trauma.
Okay, so we got up to thinking about risk assessment, and I guess, you know, one of the reasons I want to come back to the issue of risk assessment is that I think that systems, schools or mental health services or even clinicians in private practice can get particularly focused on the idea that if we assess risk frequently or talk about risk all the time, we're somehow going to reduce the risk. And I think I want to introduce the idea that we need to balance things. We do need to assess risk, but we also want to keep a different focus. Otherwise, we become a bit more obsessed and even dominated by the process of discussing risk eternally, and we don't leave time for what else might actually be beneficial. So I'm going to introduce some ideas about what might be the downside of getting focused on risk assessment. So one is that there are a number of myths surrounding the process of risk assessment. One is that we can actually predict risk in individual patients. So what we know is that all of our understanding of what are risk factors for suicide and self-harm comes from groups of individuals, groups of people, not individual people. And the reason why that's important is that we then apply a risk assessment to an individual, and the understanding that we have of how risky somebody is or their situation right now is only going to be informed by the group data, not and we have no way to predict actual individuals' risk. The second thing is that we have an assumption that people in the high risk category are going to be the ones who are most likely to die by suicide. Therefore, we need to be focusing on the high risk ones and not the medium risk or the low risk people. And actually, that's not the case. The high risk group is really quite small. They usually do get a bit of attention from us, and that's a good thing. But we also need to be mindful that our risk or allocation into a moderate risk or a low risk group doesn't mean there's no risk associated for those people. That actually the number of people who die by suicide is probably higher in the low risk group. And that's something we're just going to have to live with and understand, and we need to be careful about applying those high, moderate or low risk categories, especially if we think that the high risk group are the only ones we need to attend to. The third thing is that we also have this assumption that if we address and treat risk factors, that will be lowering the suicide rate. And that is something that actually we don't really know. We do know that it's a good idea to manage some of those things, and we want to reduce stigma, and we want to do things like help people feel connected. But by addressing risk factors, we don't necessarily reduce the suicide rate or risk for an individual person and the suicide rate overall. We also assume that if we just increase the number of risk assessments that we do, that somehow that's going to reduce the risk that we might see in an individual. And that's also a myth, that just doing risk assessments isn't necessarily going to do anything to that person's risk. Another myth that we have is that if something terrible happens and someone does end up dying, that's automatically come from inadequate risk assessment. And I think, you know, this is something that we need to educate ourselves and our communities and our workplaces, that actually it doesn't always mean that there hasn't been adequate risk assessment. Sometimes these things do happen, and all the risk assessment in the world may not have prevented that. I also wanted to say something about the fact that risk assessment and the process of doing a lot of risk assessment can also end up being unhelpful for us. And that's because when we're very concerned about somebody's risk, we end up becoming more anxious and sometimes becoming more and more controlling. And those the actions that can come from being anxious and controlling can send the wrong message to the young person, and it can send the wrong message to other people around the young person, and it can inadvertently actually increase the risk. So if a young person is already struggling and we become anxious and controlling, we can actually make things worse. And so we need to be really quite thoughtful about risk assessment, when we do it, and whether it's helpful to do a lot of it. So what can we do about this uncertainty? I think it's important to acknowledge it. We need to know that our predictions are our predictions of rare events are not very good. We need to know that sometimes we'll get our predictions wrong. So sometimes we predict that this won't happen and it might, and sometimes we predict it might happen and it doesn't. So we can go either way and get things wrong both ways with our predictions. And we need to understand that just doing more risk assessment doesn't necessarily help. We need mostly to, rather than focus on the risk assessment, focus on the individual person in front of us. And so we need to be less focused on ourselves and our own risks, and that's particularly for organisations. That's usually the pressure to do more and more risk assessment. We need to be much more interested in what is it that will help this person feel like they want to live instead of die, or live a more functional life instead of self-harming. And so we want to be thinking about how do we really listen and understand what it is that this person's doing this for. What is the function of their self-harm or their suicidal behaviour? What do they need to learn? What do they need to discover about themselves or about life? What kind of goals work towards? What is it that will build their hope and their desire to live a more functional, adaptive life? So, a word of warning, we're really not saying don't bother to assess risk, but we are saying know the limitations of our risk assessment and be realistic. And we can focus on hope and we can have an optimistic message. There are interventions and there are responses that are helpful, and we'll get on to that now. Lee, is it useful to stop it all at this point for any more questions?
Yeah, I think it is. I'm just, sorry, I'll come into screen. There's been quite a few. Thank you very much. That makes us feel like we're actually doing something.
Like we're talking to
yeah. It's hard to know. So I've actually themed them, but we will try, if you feel like your question hasn't been answered, you can send it in and we'll try and answer frequently asked questions or theme them again.
At a later time. Yeah. So just before that, we are going to get on to interventions and responses.
Yes.
If there's any questions about what we've discussed so far.
The only one that in particular around risk assessments is someone's asked then, do you think, they've made the comment, yeah, that I think we should be looking out for being too controlling, which was a good comment. But this person also asked, is it better to have a written formal plan for everyone? Or do you have like an individual plan with people? What would you recommend, or what do you do?
I think you can have some principles in mind that might apply to most people. And so even if you haven't done a lot of talking about risk with somebody, you might have some principles that could apply to everybody.
Yeah.
And then I think you do need to individualise it as much as you can.
Yeah.
So I think it's a bit of both, actually.
Yeah.
It might be that you have a conversation with every young person that you see about suicide and self-harm, because it's a common problem.
Yeah.
And you might say, these are the kinds of ways that we respond. We want to work with you. We would like you to let us know how you're feeling, and if things ever get too desperate for you, or you think of suicide or self-harm, you let us know so that we can help you with that. So you might actually have some things that you talk through with young people on a regular basis, or with everyone, and then there might be, okay, now how do we make a plan that's going to work for you?
Yeah. And we know now that contracts don't work. I don't know if you want to make a comment about that.
Well, I think there were some times, in the past, I guess, where people advocated making a contract with somebody. So really asking somebody to promise not to hurt themselves or not to attempt suicide. And they got people to sign a piece of paper saying, yes, I promise not to do this. We know that actually if somebody's really desperate and really committed to doing something like that, they're not going to care whether they wrote their name down on a piece of paper for you. They're going to go ahead with whatever plan they think is the right one for them. And so having a piece of paper shouldn't make us feel like we've done our job.
Yes.
Because actually it's pretty clear that that's not enough. That it's not about getting someone to promise something, it's about how do I find a way to work with somebody that actually inspires them to live.
Yeah. Correct.
Yeah.
Thanks.
Okay, let's move on and talk about some responses. I've kind of divided these into the immediate responses and the short to longer term ones. I'm not really going to talk much about immediate responses because I think you need to go through that in your risk training. The basic kind of things to be thinking about are, does the person need first aid, and what might be harm minimisation? And there are mental health first aid guidelines about how to respond to somebody who's self-harming in the moment or in a longer term. So there's mental health first aid, and there's other sorts of guidelines that are really very clear and concrete. And I think if you have any concerns about how to respond immediately, go look those up. what I'd like to spend a bit more time thinking about are what are the interventions for self-harm, and we can divide those into the really very short, brief sort of interventions and then the longer term treatments. So there are some examples of very short interventions, and what I mean by very short are offering who come into emergency departments having self-harmed, offering them 1 to 3 sessions within 24 or 48 hours to sit down and talk about what's going on for them, to plan how they might respond to crises in the future, plan what sort of goals they would like to work on, and then to find them some assistance to work through those goals. So we have green card clinics or gold card clinics in New South Wales and probably other areas. There have been studies of advanced care directives and whether they're helpful for people, and collaborative crisis plans. And people have found they don't necessarily immediately change the self-harm rate, but they can help people feel listened to, feel like they have a plan, feel like they have some direction, and feel like they have a little bit more control over the crises that they're experiencing. I think one of the interesting things to come out of the collaborative crisis planning study was the discussion about what recovery might mean for somebody who's self-harming, and what is it that they're hoping for, and how could we have those goals be realistic. So I think there's been some quite good work in that very brief sort of intervention category. And then if we think about what sort of interventions are the medium to longer term sort of interventions, there have been several studies that have looked at things like dialectical behaviour therapy for adolescents and mentalisation-based therapy for adolescents. Both of those treatments were developed for adults with borderline personality disorder, and they've been adapted for adolescents, and both of those studies have come out reasonably recently, and both of those found a reduction in self-harm compared to their treatment as usual. So we have some examples of studies that are effective. The tricky thing about those kinds of treatments are that they are relatively intensive treatments, and they're relatively difficult to access for the majority of young people. If we have 16 or 20% of young people under the age of 25 having self-harmed at some point, those people are not all going to be able to access these kinds of intensive treatments. So what we need to be thinking about is how to respond to the majority of people who may not have access to those sorts of treatments. I'm definitely not saying we should reduce those programs, because I think those programs are very valuable, but they're going to be probably ending up treating the people who have the most chronic, difficult patterns of self-harm, and less likely to be available to the people with less chronic kind of complex patterns. We also know that there are a range of other treatments that can be perhaps more broadly focused, not just targeting self-harm, that also can reduce self-harm. So there are a number of treatments that Brent reviews in that clinically focused review paper. Then he really clearly says are helpful and can reduce self-harm, but they're not specifically targeting only self-harm. So I think the message is there are a range of treatments that we can access that help people learn how to ask for care more appropriately, that help people identify social supports and connections in the community, and that help people develop more adaptive coping skills. And all of those treatments are likely to assist and reduce self-harm as well. We also know that if we focused on perhaps the group that are more likely to be engaging in more chronic kind of pictures of self-harm, not all of those people are going to have BPD, but some of them might. We know that there is increasing evidence that good quality, simpler treatments, those ones that are structured and manualised, that are collaborative, that are goal-focused, and that require the clinicians to have supervision, that those kind of treatments can reduce self-harm. And so I think that's good news for the majority of people who work outside of the tertiary mental health system, and for people that are wanting their young people or the young people that they know to access better care. So as we keep getting the message that simpler treatments can reduce self-harm and can assist young people who are self-harming, then more are likely to get some access to those treatments. I think it's also useful to remind ourselves that there are lots of online and web-based supports for young people that are feeling stressed and maybe engaging in self-harm. I don't know that we have very many randomised controlled trials and evaluations of those programs yet, but increasingly we will have, and certainly they can be used alongside other interventions as well for greater support and things like that. So there are lots of e-tools available, and I think I would encourage people to use those more in a careful, thoughtful way. So just to summarise what we know from all of those studies and reviews about what can be helpful for young people who self-harm, clearly having education is important. Not only education about self-harm, but education about what other mental health problems people might be experiencing. And having some sense of prognosis or the outcomes and how long things might take to get over is important. Having treatments that help people develop or continue to engage with the future and thinking about functional goals are really important. So whatever the reasons for living, how do we build those? And how do we focus more on those rather than focusing all the time on the reasons for not living? We want to build coping skills, and most of the programs that are successful incorporate some level of skill building, and even simple sort of interventions like teaching people problem-solving skills can be effective. We want to help people tolerate negative emotion, and particularly if that's one of the reasons why they're engaging in self-harm, if their tolerance is low, then it's going to be really important that we target that particular issue and help people understand things like, my negative mood will pass, and life won't always feel this hopeless for me, that people can see the ups and downs that we all know are normal. We want to encourage connections and social relationships and to build supports for young people. And we want to encourage their strengths. So what do they do well? What do they know works for them? And how do we build those things? We want to include families where we can. And of course, often young people think it's going to be unhelpful to include their family. And so I think that's something that is often quite tricky for the adults around a young person. How much do we engage young people and young people's families in the work that we're doing with young people? I've just had a conversation today with someone, an ex-patient of mine, who said the family involvement was really difficult for her. So I think it's commonly a difficult thing, but I would also add that families really want to be engaged most of the time, and I think it's helpful if we can work with the whole system rather than just with one person in the system. So the more we can involve families in a helpful way, I think the better. And of course, self-harming is effective in getting help, but it's a pretty unhelpful method for getting help. So we want to encourage people to become better at asking for help when they need it, and to be more effective at that. And so actually teaching people how to ask for help more effectively can be a really important component. I do want to have a few minutes to think about what we do in response to really difficult, challenging, complex patterns of recurrent self-harm, because I think that's probably the issue that's most challenging for people, for clinicians. commonly that's when people start to realise that if they self-harm and tell people about it, that they will go to hospital, and sometimes that can feel like a really good option when things are not doing so well, or when hospital looks so much nicer than home. Alternatively, sometimes people go to hospital and then discover that if they say things to the team about feeling unsafe, or that they self-harm on an inpatient ward, that will mean that people don't discharge them as quickly, and if they're feeling unsure about going home, that can seem like a really good way of affecting that. So I think they're two common patterns. They're not the only ones by any means, but we certainly do see that starting to emerge sometimes. What I think is really important is that we have to be careful not to assume that every young person who self-harms is automatically trying to do this. And I think it's really useful to remember that these are patterns that we teach people. They're not patterns that people start off or spontaneously decide when they start self-harming. These are patterns that emerge over time, and our responses are the things that make these patterns become more stuck. So as a result of that, we need to be quite thoughtful about our responses when people are self-harming. I think it's really important to say, in our work, in our early intervention for borderline personality disorder program, HYPE at Orygen, we don't ban anyone from hospital. So we don't say, even if you're developing this kind of pattern, you can't go to hospital. But I think we do try and address those sort of patterns quickly if we see them emerging. So we acknowledge that self-harm does elicit care. But it's probably true to say that for most people, it's not always the care that they most want. Most people want care from the people in their life, not care from strangers. And so if we can work with a young person to think about the development of that pattern, who is it that they really want and need care from, and how do we help them get that? That usually then we can start to shift that pattern from emerging. And I think it is also fair to say that for people that are developing those sort of patterns, we do want to make sure that hospitalisation becomes the last resort, that we get used to trying many other ways of managing distress and managing difficult situations before we resort to hospitalisation. But I think it's also important to say it's rare that we would decide to refuse hospital admission on the basis of this sort of pattern. That really what we don't want to provoke is people upping the ante and engaging in more and more severe sorts of behaviours. And I think that's what commonly happens if you refuse admission. So we try and deal with these sorts of patterns emerging by being very open and direct, not blaming, but engaging. So we want to have a collaborative discussion with young people about the emergence of those sort of patterns and try and understand why that might be emerging for them and how we can manage that. For young people who feel not heard, then we can talk about how do we show you that we're listening to you. For people that are saying, you know, you're discriminating against me, or you're refusing me admission and prioritising others, we can have an open discussion about that, because sometimes that's actually true, that some people's mental health concerns might mean that they get prioritised above the person with self-harm. And so I think we need to be open and honest about some of those decisions that we make at the emergency department level or the CAT team level, because some of those things young people can see that they're happening, but when we cover them up or are not open and clear about them, then we invite them to also be not clear about what it is that they're wanting and to act out their requests to us, and that's what we want to change. So I think it's also important to think about our management of really risky sorts of situations, particularly when there's a developing pattern of persistent, recurrent sort of suicidal or self-harming behaviour. We talk about clinically indicated risk-taking, and what we mean by that is that sometimes we decide to take short-term risks for longer-term gains. So we say to the young person, if we are always responding to the short-term risk, which is that you're going to harm yourself, that what we seem to be doing is reinforcing dependency, reinforcing the message that we can't trust you to manage yourself, that we don't think you're able to take care of yourself. And what that does is it undermines young people's ability to grow and learn and improve their own caretaking of themselves. So I think when we do need to take short-term risks, we need to be clear and open with young people, and we need to be really clear with the rest of the service and the management and the people that will be backing us up in those decisions. Clinicians should not be making those decisions on their own. It needs to be a whole service decision, and if you're working in private practice, that means you need to really involve other clinicians with you. So I wouldn't, as a clinical psychologist, be making those decisions on my own. I would have a psychiatrist or someone like that who could also be involved in the decision making if I was going to be taking short-term risks like that. So I think, you know, the bottom line is seek guidance, agreement, consult before you do those things, but there are definitely times when it is appropriate, and it requires a coordinated approach to be able to do those sorts of things. When we're thinking about risk-taking behaviour, including self-harm, what do we need to be doing? We need to be focusing on the individual. We need to be balancing things like our duty of care. Containment isn't always the best response when people are engaging in risky sort of behaviours. Our responses can make things worse. Our systems can make things worse. So we need to be realistic and thoughtful and reflective. We need to stop and think and review. We need to think, are we moving in a direction that is improving things, or are we inadvertently actually going backwards and reinforcing unhelpful methods or messages? Monitor individual risk, and we really need to focus on the immediate risk, but on the background of the chronic kind of or static sort of factors, and we need to consult a lot with other staff. Another thing that I think is really important to remember is that we document what we do and why we do it. Ooh, sorry about that. I have to quickly go backwards. We need to understand that if we don't write things down, if in the worst case scenario something bad happens or someone needs to read our notes, if we haven't explained exactly why we're making the decisions we're making, no one else will know that we've thought through things. So when you're thinking about what to write in your notes, I think the basic message is explain everything. Explain your thought process, explain why you chose to do things, but also why you chose not to do other things. And make it easy for the reader to understand why you did what you did.
I'm going to interrupt you because we have an important question.
Okay.
Just on what you're saying around short-term risk and long-term risk.
Yeah.
What do you really mean? Can you give maybe a clinical example?
Okay. I have actually a very recent example in mind. So in our program at the moment, or actually recently, we had somebody who was engaging in quite a lot of self-harm, and was on the inpatient unit, and being on the unit wasn't really reducing the risk for that person. So they would go on leave and engage in self-harm or bring things back into the unit in order to self-harm and self-harm on the unit. And so the conversation with that young person was, we want to keep you safe. However, coming to hospital doesn't seem to have reduced your risk. So perhaps you should go home and we will continue the work in the community. Because staying in hospital takes up a lot of resources, limits your freedom, gives you the message that we don't trust you, gives you the message that you can't do this on your own, and may also inadvertently make you more dependent on us.
Okay.
So in that situation, we knew that that person was quite likely to go and self-harm.
So in the short term.
Yeah, once they left the unit. So the short-term risk was we're discharging you knowing that this may happen, but we really want to work with you about the long-term risk, which is that you don't learn any ways of managing yourself. So we want to work with you about those things. We want to encourage you to develop better skills. And we think you'll learn that better out in the community.
Mm-hmm. Thanks.
And so, in that example, that person was gradually able to feel more contained in the community. And yes, of course, they did self-harm when they were in the community because they'd been self-harming in the community and on the unit.
Yes.
So staying on the unit hadn't really changed that.
Right. And you wrote it up that way in your notes.
Yeah. And we consulted with senior staff and we made sure that the family knew that this is why we were discharging the person. The young person knew. They weren't very happy about it, but we had to talk with them about the reasons for doing that. And they weren't completely opposed to it. They could understand the reasons.
Great.
Yeah.
Thanks.
Okay. So we're very close to the end now of the slides anyway. I just wanted to come back to the idea that we also need to be mindful of our own reactions, that we all have responses to working with self-harm and being around people who talk about suicide and self-harm. And sometimes that can really precipitate strong reactions in us. And it's important to pay attention to how we're going, that we're not a blank slate in the whole process, that actually in all our work with young people, we're in a relationship with them, we're in a conversation with them. And what they say to us impacts us and affects us, just like we hope that what we say to them impacts and affects them. So I think it's important to remind ourselves that we need to pay attention, not ignore our own responses. It's important because if we just pretend they're not there, sometimes they can swamp us and we suddenly realise we're struggling way past when we should have noticed it or way past where we think it's tolerable. And at times like that, it can interfere with our work. We can say the angry thing or the irritated thing or the perhaps controlling thing that if we stopped and thought about it and attended to our feelings a little earlier, we might not actually say. The other thing is that we need to model how to care for ourselves, for our young people. That it's important for us to look after ourselves, but it's also important for young people to see us looking after ourselves. So we don't come to work when we're really, really stressed and overwhelmed. Or if we are overwhelmed by what they're telling us, we take a break and we go and do something or get someone to help us when we need it. The best ways to stay on top of all of that is to make sure you have regular supervision, that you consult with others, that you talk about your experiences and how you're managing with those things. You don't need to give personal information out to be able to connect with people and to say, I'm struggling with this kind of experience. And so I'd just like to end on that point that looking after ourselves is a very important message to communicate to young people. Okay. I think that's it.
No, it's not. It's not over.
Do you want to go through to the end of the slides just because we've got some housekeeping, or do we stop at this point?
Yeah, maybe we do the housekeeping and then we go on to the discussion. We do have a few questions though.
Well, we've got some time for questions after this till 2:30.
We've got till 2:30, yeah. Let's go housekeeping.
I would like to go through them then.
Okay.
So thank you everybody for watching. And for all your questions. I can see that there's quite a lot coming up on the screen there. The webinar has been recorded and will be available on the campus page of the Orygen website. Lee's already said registrants will receive an email saying that they've attended, and there will be resources available when the slides go up. I'm just going to flick through the kinds of resources that we're going to have in on the website.
Yep.
So there's a whole range of useful resources that are for young people specifically, and these websites have downloadable sort of fact sheets as well as information that people can engage with.
And there were quite a few questions actually around e-tools or apps. And if you go to, I actually didn't put your CRC up there, so the Young and Well Centre. People can look at that. But also Youth Beyond Blue and Reach Out have a page, I think, of recommended apps and e-tools.
Yeah. Okay, good. And then for professionals, the place to start is probably the National Suicide Prevention Strategy. There are quite a lot of different sorts of guidelines available. The College of Psychiatrists endorse the NICE guidelines. NICE is the National Institute for Clinical Excellence in the UK, and they have very comprehensive guidelines, and so they're available. You can just go straight to the NICE website if you want. There are Mythbusters available through our Orygen page as well as through the Headspace website, and there's school supports listed here. Safe Minds is a school's resource, and then there's some other ones for professionals there.
Yep.
Okay. This is a little bit of promotional material. There's some online training certificate in young people's mental health and technology available through our Orygen website. And there's another webinar coming up in the near future on the 24th. That will be Dr. Alex Parker, and she'll be talking about using psychoeducation in youth mental health treatment.